point, I'm going to turn things over to Dr. Reed, and he will give the body of the presentation. And then again, we will be back at the end with our poll questions and with questions and answers. Dr. Reed currently practices at Rheumatology Associates PC in Indianapolis and has a professional history with Indiana University Health as well. His academic appointments include assistant professorships in medicine and pediatrics, as well as clinical medicine, both at Indiana University School of Medicine. He is board certified for internal medicine, pediatrics, and rheumatology. And Dr. Reed specializes in rheumatology and osteoporosis. So at this point, I will deactivate my camera and microphone and
Hello, I appreciate being asked to lead this discussion on rheumatoid arthritis today. And we're going to talk about rheumatoid arthritis, how it's different from other forms of arthritis, the symptoms and the treatments, and feel free to ask any questions along the way. So arthritis is a general term meaning joint problems, and it affects about 60 million Americans. And it's only second to heart disease in causing disability in this country, and the costs are quite high. The U.S. costs are over $80 billion, and that's not only treatment costs and evaluation, but lost wages. We see arthritis more commonly in women than in men, and it does limit everyday activity for millions of Americans. So there are hundreds of different types of arthritis. The most common arthritis that most people are familiar with is osteoarthritis. That's a degenerative form of arthritis, often resulting from wear and tear. It becomes more common as we get older. Rheumatoid arthritis, of course, is an arthritis that's due to inflammation in the joints, and we're going to talk more about that. Gout is a form of inflammatory arthritis that tends to occur intermittently. It's caused by crystals in the joints and soft tissues, and it causes fairly debilitating attacks that may last a week or two and clear, but it requires treatment with medications to lower the gout levels. Psoriatic arthritis is a form of arthritis that people with skin psoriasis can develop. About 10 to 15% of people with skin psoriasis will develop that arthritis. Patients with lupus can have an inflammatory arthritis. Septic arthritis is an infection of the joint, and it usually comes from some other place in the body. The infection will spread through the blood to the joint. Lyme disease is a unique arthritis caused by a certain infection that is carried by ticks, ear ticks. And these ticks are quite small, nearly impossible to see with the naked eye. And it's often seen in certain regions where it's more prevalent. Ankylosing spondylitis can have arthritis and inflammation of the spine. And then the CPVD arthritis is similar to gout, except instead of uric acid crystals, it's calcium crystals that deposit in the joints. And it can behave much like gout. In fact, we call it pseudo-gout when it does that. And then there's other conditions where there's inflammation of blood vessels that can lead to arthritis as well. So today, though, we're going to focus on rheumatoid arthritis. Now, rheumatoid arthritis has about a prevalence of about 1% in the U.S., so about 2 million people are affected by this condition. And women outnumber men 2 or 3 to 1. It can actually occur at any age. Usually occurs in the 30s through 50s, but children can develop rheumatoid arthritis. We see many patients develop rheumatoid arthritis even in their 60s and 70s. And it's a chronic disorder which causes inflammation primarily in the joints, but it can affect other organ systems. And we can see most commonly side effects in the skin, the lungs, the eyes, the heart, and the salivary glands. So it's a systemic process. It's not just isolated to the joints. So when we think about arthritis as rheumatologists, our first sort of division is trying to decide if somebody's experiencing inflammation of the joints or whether it's more of a mechanical degenerative type process. And so this slide here compares the normal knee to a knee with rheumatoid arthritis or a knee with osteoarthritis. And I'm going to try to get a pointer up here. So the normal knee has nice smooth cartilage on the surfaces that touch each other, and the joint capsule is nice and thin. That's that light pink, there we go, material there. Just inside the joint capsule is the synovial membrane. The synovial membrane nourishes the joint, and then the synovial cavity is where there's a small amount of fluid inside of the joint. In rheumatoid arthritis, what happens is the synovium thickens, it becomes inflamed. Along with that, you'll get a thickening of the joint capsule, and with that, you'll start having inflammatory cells inside the synovial cavity, so that space inside of the joint, which then can lead to cartilage damage. Now compare that to osteoarthritis, where the synovial lining really doesn't thicken to any great degree. The joint capsule is fairly normal, but what happens is you start getting cartilage loss, and we don't know really what leads to that. You'll get these loose bodies in the joint, these irregular surfaces, and then occasionally new bone formation with bone spurs. But the osteoarthritis joint doesn't have inflammation cells in it to any great degree. So what exactly is happening in the joint with rheumatoid arthritis? Well, it's the immune system that is basically attacking proteins in the joint. It's attacking proteins in the synovial lining, which then is leading to inflammation in the joint, and that inflammation leads to destruction of the cartilage and then the bone. So one question is, well, why do people get rheumatoid arthritis? What's the root cause of this condition? And the actual etiology of this condition is unknown. There's a genetic predisposition in some patients, so patients with a family history of rheumatoid arthritis are at some increased risk for developing that condition. There's certain ethnic populations that we see it in a greater frequency, certain Native American tribes. There's even a genetic marker present in some patients with rheumatoid arthritis, which puts them at higher risk for disease. And then there's been lots of interest in looking into environmental exposures, things that could start the whole process, such as bacteria or viruses or things in our diet that may set things off, but nobody's been able to identify a specific causative organism or exposure. We do know that cigarette smoking actually increases the risk in many patients, and stopping smoking can reduce that risk. There may be a role of hormones in the development of rheumatoid arthritis. Of course, we see the condition more in women than in men, and so perhaps that estrogen exposure has some role in promoting autoimmunity. And then just our immune system in general puts us at risk for developing rheumatoid arthritis in some patients. So what are the symptoms of rheumatoid arthritis? Well, this slide will describe symptoms that we see in all forms of inflammatory arthritis. We see pain and swelling in the joints, and it typically is visible swelling. In rheumatoid arthritis, it's a symmetric condition, so the left side of the body often looks just like the right side of the body, and the involvement of joints is fairly symmetric from one side to the other. Morning stiffness is a hallmark of inflammatory joint disease, including rheumatoid arthritis. People are quite disabled by stiffness for an hour or longer every morning. Many patients with rheumatoid arthritis are unable to make a fist because of the stiffness and the swelling in those joints. Unique to rheumatoid arthritis are these subcutaneous nodules. People can get lumps under the skin, most commonly occurring on what we call extensor surfaces like the elbow, or sometimes around the ankle and Achilles tendon, but some people will get nodules on their fingers as well or on the bottom of the feet. And sometimes they're painful, sometimes they're not. And of course, joint deformities are a later stage change in rheumatoid arthritis. And there can even be non-joint symptoms, and those are usually symptoms of inflammation, so fatigue, sometimes low-grade fever, low energy. Some people lose appetite, but fatigue is a very common symptom of chronic inflammation. So morning symptoms are what are prominent in inflammatory arthritis, like rheumatoid arthritis, waking up stiff, puffy, swollen joints. And many of those symptoms will improve as the day goes on, but oftentimes they don't completely clear. So this photo demonstrates the kind of swelling that we see in rheumatoid arthritis. It's not easy to see, but you can tell here in the wrist that there's some bulging in that wrist area, as well as in the left wrist. You'll see swelling, particularly in the first row of knuckles here, and then the second row of knuckles is another prominent area of rheumatoid arthritis. Curiously, the knuckles, the joints closest to the nails, are generally unaffected by rheumatoid arthritis. In this photo, it looks like there may be some swelling in this joint, but that probably is more of an osteoarthritis change. If I could examine the patient's hand, it would feel hard and bony, whereas these joints in here would feel fluid-filled, soft, and squishy, as I call it. All right. And then later stages of the rheumatoid arthritis condition leads to joint deformities. So people will get this sort of splaying of the fingers to the, out towards the pinky side of the hand. We call it ulnar deviation because the ulna is the bone in the forearm that's on this side of on that side of the arm. And then you get progressive thickening of the synovium, which then leads to this sort of thickness all along the knuckles there. These fingers you can see are starting to get angular changes. They call those swan neck deformities. And those are all late stage changes of rheumatoid arthritis. It's our hope as rheumatologists that now in 2015 we don't see very many people showing up with these changes. We count on our primary care colleagues and our orthopedic colleagues to catch things before it gets to this point. This is a picture of a rheumatoid nodule. It's hard to tell, but it's sort of this lump right here, and that's on someone's elbow. Many times they're symptomatic when they lean on a table or a chair, and those can be surgically removed if they're causing some symptoms. Most of the time they're relatively asymptomatic. So we'll move on to how we make a diagnosis of rheumatoid arthritis. Much of the diagnosis is based on the history that the patient describes. Going back to the symptoms that we discussed, patients will come in and describe stiffness in the morning, inability to function for an hour or longer because of the stiffness and pain, puffy, swollen joints. Fatigue is often seen. Sometimes rheumatoid nodules are present upon initial presentation. And there are different ways that rheumatoid arthritis can start in patients. Most patients will start with a fairly symmetric onset of multiple joints involving the hands and the feet most commonly, but almost any joint can be involved. That's probably the majority of the time patients have a fairly rapid onset of joint symptoms. There's some people that will have more of an additive presentation where they'll have one joint that bothers them for a while it may quiet down, but then another joint starts to bother them, and they start developing more than one joint at a time, and eventually a fairly typical pattern of symmetric arthritis. There's a small subset of folks who have an intermittent arthritis where they have intermittent episodes of severe pain that may last a day or two, and then it goes away, and it'll be in just a single joint, and then days or weeks later it may occur in another joint. And that subset we call palindromic rheumatism. So there are different patterns of how this can present. And there are viral infections and other types of acute arthritis that can look just like rheumatoid arthritis. And those can be quite disabling as well, but they're self-limited, meaning that they get better on their own. There's a virus that affects children, usually in the preschool years, that causes Fifth disease that can also cause an arthritis in adults. It's called parvovirus. And so when we're evaluating patients with inflammatory joint symptoms, the length of time that the symptoms have been present is important in distinguishing from an acute process versus something that may be developing into a chronic process. So we usually reserve diagnosing a chronic arthritis until at least 8 weeks of symptoms have been present. And so moving on to the blood testing, of course there's two markers of rheumatoid arthritis in the blood. One that's been around for many years, decades, is the rheumatoid factor. And rheumatoid factor is present in the majority of patients with rheumatoid arthritis. A newer marker of rheumatoid arthritis called CCP antibody has been used over the last decade or so. And we generally will check both of those tests in patients presenting with suspected rheumatoid arthritis, and it just helps to firm up the diagnosis. Unfortunately, they're not perfect tests, and one or both are present in only maybe about 80% of patients, so there's still 1 in 5 patients with classic rheumatoid arthritis who won't have either one of the blood markers. And so it's always important for our primary care colleagues to have a high suspicion of rheumatoid arthritis in patients with inflammatory joint symptoms and not completely rely on the laboratory testing, but it's still important that they do those tests. Other lab tests that are done in evaluating patients with inflammatory joint symptoms are blood markers of inflammation. There's two that we use, one called SED rate, one called C-reactive protein. And those are generally quite elevated in patients with rheumatoid arthritis. But again, many patients present with obvious joint inflammation and have normal inflammatory markers, so those are not perfect tests either. Many patients will present with anemia on their blood counts, and that can be a clue. And we always check basic chemistries just to assess kidney function, liver function in anticipation of treating these conditions. X-rays can be helpful. Some patients, even upon initial presentation, will have changes on X-ray that are typical features of inflammatory arthritis and rheumatoid arthritis. The most useful areas to X-ray are the small joints of the hands and feet. We see more changes in those smaller joints than we may in a larger joint. MRI can be used if patients have symptoms but not obvious findings on examination. And MRIs will give very nice pictures of joint inflammation or even damage related to chronic inflammation. So there are a number of tools to help us in diagnosing rheumatoid arthritis. But the most important piece is the history and the physical exam. We need to have a history consistent with inflammatory joint disease, and we have to have physical exam features of small joint swelling and warm, swollen joints in the larger joints. This is an X-ray of a hand affected by rheumatoid arthritis. Prominent features of this X-ray, here in the middle finger, you see there's almost complete loss of the joint space. The adjacent joint actually looks pretty normal. Another soft sign that we see in the X-ray is this darker change to the bone. Bone typically has fairly uniform white like you see in the midshaft here, but around the joints of patients with rheumatoid arthritis we'll see this sort of darker change, which correlates with reduced calcium content and what we call thinning of the bone or osteopenia. Over here we have what is probably an erosion. It looks like somebody took a bite out of that bone. And so erosions are features that we look for on the hand and foot x-rays to help support the diagnosis. Although our hope is that we don't see erosions when we first order our x-rays. This is an MRI, and the MRI is demonstrating some typical features of rheumatoid arthritis. Let me get my pointer here again. I'm going to go over to the upper right one there, and you can see that bright bone there. That brightness is what we call edema or swelling in the bone. The joints that are affected by rheumatoid arthritis will often cause some adjacent bone edema. This one in the upper row, the second one from the left, you can see a loss of the kind of the edge of the bone on the top there, and that's probably an erosion in that bone there. We don't very often obtain MRI imaging to make the diagnosis simply because the clinical presentation is usually fairly obvious, but sometimes we'll have patients who are referred to us by orthopedic specialists who obtained an MRI for an evaluation of the patient's joint pain, and they find these erosive changes and quickly get them off to the rheumatology office for further evaluation. So if someone is diagnosed with rheumatoid arthritis, they're always concerned about what to expect. Many times now people go out on the internet and start to research rheumatoid arthritis and start looking at images and see those images of the crooked fingers and the deformities and become quite anxious about the diagnosis. And certainly that is a risk with this condition, but early diagnosis and treatment is really having a huge impact on the outcomes, and patients nowadays, if they present early or treatment is initiated early, very rarely develop the kind of joint deformities we saw in those earlier slides. Of course, rheumatoid arthritis is a chronic condition. Once it develops, it only rarely goes into remission. 5 to 10% remission rate has been reported. We are seeing now some patients who go on early treatment, especially with advanced therapies. After a couple of years of treatment, sometimes the treatment can be withdrawn and they may have a sustained remission, although most of those patients will relapse. If we don't treat the condition early and aggressively, most patients will develop some damage to the joint and to the bone, and usually that's within the first 2 years. So it's really critical to have a high index of suspicion and to evaluate these patients quickly and get them to rheumatologists quickly. This next piece of data, 5 to 10% of rheumatoid arthritis patients become disabled every year. That's some old data, and it's much lower now with early recognition and treatment. Many patients are continuing to have productive lives and are able to function the way that they did prior to developing disease if identified early. This condition can be associated with increased risk of infection. Chronic inflammatory disorders like rheumatoid arthritis have been associated with a higher risk for cardiovascular disease. And lymphoma, which is a cancer of the lymph nodes, is seen at a much greater frequency in patients with rheumatoid arthritis, even if they aren't on any of the medicines. Of course, when you listen to the ads on television for some of the drugs, you hear about lymphoma, and It's possible that some of the drugs may have an association with it, but simply by virtue of having rheumatoid arthritis, the risk for lymphoma is increased. So what's the good news about this condition? Well, the best news is that the better treatments that we have than we even had 15 years ago. There's been advancements in making the diagnosis with the new antibody CCP, as well as more advanced imaging options. Of course, there's ongoing research in other ways of manipulating the immune system, stem cell transplants. People are looking at gene therapies, but we're not there yet. So what we're currently able to do is manipulate the immune response pharmacologically. So treatments have been the big advancement. When we're treating patients with rheumatoid arthritis, of course, our first goal is to improve symptoms. We want patients to have less pain, less swelling, less stiffness in the morning. We want people to be able to function normally. And then our secondary goals are to prevent damage. We want to prevent erosions and joint deformities. And so again, we want to identify people early and try to get them on appropriate therapies early on in the condition. And of course, we always want to minimize risks of adverse events from the medication, so we're always balancing the risks of our treatments with the risk of developing deformity and disability. So let's talk about how we treat rheumatoid arthritis. Rheumatoid arthritis is a robust inflammatory process, and so we have to use medicines that impact that inflammation. We have a group of agents that we call disease-modifying anti-rheumatic drugs, or we use the term DMARDS. And the DMARDS have been used now for, 3 or 4 decades to control rheumatoid arthritis and have done very well in having an impact on slowing progression of disease, preventing damage and disability. Steroids, of course, are still used fairly extensively. They work the fastest of all the agents that we have, but steroids over the long term can have side effects that we'd like to avoid, and so we're happy to have medicines like the DMARDS or our newer biologic response modifiers. And the nonsteroidal anti-inflammatories, what we call NSAIDs, do have a role in rheumatoid arthritis, but primarily their role is to treat symptoms. They reduce pain, they may reduce some swelling. Unfortunately, they don't have a role in preventing damage and disability from rheumatoid arthritis. So things like Celebrex and Motrin and Advil and ibuprofen help with the pain, but they're not strong enough to prevent progressive disease and damage. So we use them, but we don't see them as a important piece in the treating the disease process. Joint injections can be used for severely painful joints, and they work very well. We basically inject a steroid right into the joint, and it quickly reduces inflammation and the side effects of inflammation, the swelling, pain, and warmth. And so in patients who present with a big swollen knee and they can't walk because of it, or an ankle, joint injections can be very effective initial therapies. And we often use joint injections even if a patient has a mild flare of a single joint while they're on treatment. The greatest advances in treating rheumatoid arthritis and other inflammatory arthritises are the biologic response modifiers. Those have been around now for a little over a decade and have really revolutionized the treatment of rheumatoid arthritis and really changed the face of patients with rheumatoid arthritis. And we're going to talk about all these here in a little more detail with the next slides. So let's first start with our DMARDs, our disease-modifying anti-rheumatic drugs. We have a few different things to choose from here, and they're listed on the left side there. Our most widely used agent is methotrexate. Methotrexate's been around for decades. It's used to treat cancer. But we use low doses on a once-weekly dosing pattern to control inflammation in inflammatory joint disorders. And it works very well. Many times patients can be treated with methotrexate all alone and have good control of their disease. It can be given as a pill or as a shot, and it's shown really good long-term safety. Sulfasalazine is another agent that controls inflammation and prevents damage. It's a daily agent. Hydroxychloroquine or Plaquenil is an interesting medication. It actually is a anti-malarial drug. And then Arava is another one that works like methotrexate. The ones on the bottom have fallen out of favor to some extent simply because they're not as effective as the ones on top. This next slide shows our biologic agents. These are the ones you see advertised on TV now, like Humira and Enbrel. And they're shaped just like antibodies in our own system, and they're designed to attach to certain things that drive inflammation. And so etanercept on the right there in the middle will actually attach to a protein called tumor necrosis factor, which drives inflammation in some patients with rheumatoid arthritis. So here's a list of the different things that we have. At first, the bullet point, the tumor necrosis factors have been around, the factor inhibitors have been around the longest. Enbrel is the longest running one, but Humira and Remicade have been along for a good long while. Cimzia and Symphony have been more recently released, and they all work by blocking this protein called tumor necrosis factor. The ones in the lower half of the slide block other parts of inflammation pathways, and unfortunately it's not one size fits all with our patients with rheumatoid arthritis. Some patients respond to one agent and not another. Nobody understands why that is. It's just the heterogeneity of this condition. So many times we have to do trials basically with individual agents, and if after 2 or 3 months we're not seeing a response, then we have to choose something else to treat patients with. In most cases, though, we come across an agent that works well in our patients and helps improve their symptoms and their function. This slide just demonstrates how effective these agents are. The bottom line with the white open circles is the placebo-treated patients. The top line are patients who were treated with the medication called Humira. And as you can see, going from left to right, within that first 8 weeks, there's a big difference in treatment response. On the bar on the left, you'll see what's called ACR20. That's a 20% improvement with treatment. And you can see right away, just even in the first 4 weeks, the patients treated with Humira had marked improvement in their function. So they're excellent, excellent agents. You know, and as commented by Dr. Breedveld here, that the premier data are encouraging because they suggest early and aggressive treatment may slow or inhibit patients' joint damage. And that was published back in 2005 when these agents were becoming used more widely. So there are risks of treatment, and we always balance these risks with the risks of not treating. When we don't treat rheumatoid arthritis, as we already discussed, the vast majority of people, almost everyone, develops damage in that first 2 years. But since we're suppressing immune response with these agents, there are risks of infection. There's potential liver toxicity with some of the medicines. Many patients experience gastrointestinal side effects with the oral agents. And these medications can interact with other medicines, so patients with rheumatoid arthritis always have to make sure that their other providers know that they're on certain drugs. Of course, there's concerns about cancer risk in these patients treated with these agents. We talked about the lymphoma risk, but there's still concerns about other kinds of cancer. To date, though, it appears that patients treated with medications like Enbrel do not seem to develop cancer at any greater rate than patients who are not treated with Enbrel, so that's good news. And we always have to monitor things long-term, doing lab tests periodically to make sure the liver function is normal, that the blood counts are normal. So we see patients frequently, we have them get labs periodically, and hopefully we won't see any problems. There's always questions about dietary things in arthritis. Unfortunately, we don't know of any dietary manipulations that work for these inflammatory conditions. Fish oil may have a role in reducing some of the symptoms of rheumatoid arthritis, but unfortunately there aren't any studies to support its use for preventing damage and progression of disease. The importance of exercise is primarily in keeping the joints moving normally. Exercise doesn't have an impact on the inflammatory process, but if you don't use your joints, you can lose strength and motion, and so it's always important to do simple range of motion exercises and some light weights to keep the muscles that support the joint strong. And surgery for rheumatoid arthritis is primarily reserved for end-stage joint problems, although rheumatoid nodules can be removed surgically if they're symptomatic. If there's joint deformities of the hand, joint replacements can be performed. And so surgery is an option for end-stage disease. Fortunately, nowadays, with early treatment, we're keeping people from having to proceed with surgical interventions. Our hand surgery colleagues have even commented that they see fewer patients with late-stage rheumatoid joint disease. So this slide is just a summary of what we've talked about today. Rheumatoid arthritis is a chronic condition causing inflammation in the joints, usually the hands, wrists, and feet, but any joint can be affected. If we don't treat rheumatoid arthritis, patients develop joint damage, and that results in disability. Medical treatments can halt the disease progression and improve quality of life for patients. We had mentioned earlier the increased risk for cardiovascular disease in patients with rheumatoid arthritis. We've actually now seen studies that show that treating this disease actually reduces that cardiovascular risk. So it's not just a joint disease, it's a systemic disorder that's affecting other organ systems, and we always have to keep that in mind when we're thinking about the risks of the treatment, that this condition has an impact on quality of life, length of life, and so we have to treat it aggressively, identify it early. I think that may be my last slide. I think we can probably open things up to questions.
Well, thank you very much, Dr. Reed. That was excellent overview, and really laid things out very well. So let me, while we're preparing for our questions and answers, I'm going to administer our poll questions. If you do have questions, please feel free to go ahead and enter those into the chat window. Or again, if you have a microphone and want to raise your hand during the question and answer period, we'll be glad to attempt to enable your microphone. So let me open our first question, and that simply asks about your affiliation. If you could let us know which of those categories you best fall into. We realize some of you may be in multiple categories, but just gives us an idea of where you're coming from. Give you another couple seconds there. Okay. All right. It shows a breakdown of that. Let me put another poll. Second question asks about the information that was shared today, and if you could tell us whether you felt that the information answer the questions you had? You felt like it was appropriate and met your needs?
Oh, my hands are...
Okay. I'm having to wait on my system to close the poll. Sorry for that delay. Okay. So, share poll results. The next question asks about the technology. Did you feel the technology today was effective and usable? You can let us know. If you had any specific issues, again, please let us know in terms of problems, and you can do that in the chat window. Also, I forgot to mention, if you had multiple people viewing the webinar at your site, it would be helpful to know that also, so we can count those people in their attendance for that. If you could just make a note there. Okay. Our next question asks, based on today's session, would you attend another session in the series? Okay. Appreciate your response on that. And then our final poll asks how you heard about the session today. You can let us know. All right. Thank you very much for your responses. At this point, I'm going to turn things back over to Cliff Raz, who's our IT specialist, and to Dr. Reed for our question and answer time. Let me do a little manipulation here so I can get the ball pass so Cliff can enter our questions.
Can we ask a question? Hello?
Yes, and Cliff's going to enter questions onto the screen there.
Can we ask a question, please? Oh, I see. Got it. He doesn't have his microphone on, or headset or whatever.
Okay.
Okay, so our first question is, what is the correlation between age and rheumatoid arthritis?
Okay. We can see rheumatoid arthritis develop at any age. We had discussed earlier in the presentation it tends to develop in the 30s through 50s, but there are children with rheumatoid arthritis. There are patients over the age of 60 with rheumatoid arthritis, but the peak is in the 30s and 40s.
Okay, the next question. What is the difference in prevalence of rheumatoid arthritis between agricultural and non-agricultural communities?
I'm not aware of any difference between agricultural and non-agricultural communities. There is a tendency for rheumatoid arthritis to have a greater prevalence in cooler climates. It's hard to know if that's a climate issue or perhaps something to do with the ethnic makeup of groups in different parts of the world.
The next question is there a correlation between rheumatoid arthritis and people who suffer from neuropathy of the feet?
No. People with neuropathies of the lower extremities of the feet and ankle region, though, can develop what we call neuropathic joints. The loss of sensation in the foot and ankle region has an impact on the joints and the bones, and can cause deformities that are a result of losing that sensation. And there's an interesting phenomenon in patients who have had a prior stroke affecting an extremity. For instance, if someone loses use of their right arm due to a stroke and later develops rheumatoid arthritis, for some reason, some of those folks will only have the rheumatoid arthritis in the normal arm, but not the affected arm, and it's not clear why that's the case. But I actually had a patient like that years ago, and it was a striking presentation.
We have a question, we have a hand raised by Bud Wilner. Bud, you can either type your question or we'll go ahead and enable your microphone.
Let me get the mic on here.
They turn on the mic.
Okay. Can you hear me?
Yep.
We can hear you.
We can hear you.
Yeah. What about the spinal arthritis? Arthritis in the spine.
Well, it's interesting. Rheumatoid arthritis can affect the spine, but it's most commonly affecting the neck region. We never see rheumatoid arthritis affecting the lower spine, the lumbar region, as we call it. Most commonly, if people have spinal arthritis, it's degenerative. There's an inflammatory arthritis called ankylosing spondylitis that can affect the spine, and it's an inflammatory spinal process. Oftentimes, though, it presents in the 20s and 30s, earlier in life. But most people with lower back pain have degenerative arthritis, and it's not an inflammatory arthritis and not related to rheumatoid arthritis. And people with rheumatoid arthritis who have cervical spine involvement, it won't be the only part of the rheumatoid arthritis. They have to have other joint involvement to have rheumatoid arthritis. So it's a curiosity as to why the lumbar spine is left alone in rheumatoid arthritis.
Thank you. Thank you very much.
You're welcome.
This question is a little bit bigger, so I'll try to expand it so that you can see the whole thing. So the question is, so does a correlation exist for rheumatoid arthritis or arthritis in general between hot and cold temperatures? Because a common arthritis myth states that arthritis can be caused by moving frequently from hot to cold temperatures.
So we don't see necessarily a correlation between hot and cold temperatures. Patients frequently have an impact on the symptoms from different environmental temperatures. but we don't see more severe disease in certain climates necessarily, actually I don't think we even see higher prevalence of disease in certain climates. There's rheumatologists in all 50 states and across the world, so we're all seeing a fairly similar group of patients with rheumatoid arthritis. So while temperature changes may affect symptoms, it doesn't necessarily seem to be having an impact on the prevalence of the disease at this point.
Okay, well, we'll give another few minutes for any other questions if they're out there. Otherwise, we will finish the webinar.
I just had another note for attendees today. If anybody has another question, we'll be on for another minute or so. We are having our annual web conference on December 1st through the 3rd. That'll be a series of 2 webinars per day for those 3 days, a total of 6. Some of the topics we're going to be looking at, there's one on working with migrant seasonal farm workers, outreach to those groups, post-traumatic stress disorder in veterans. Also another veterans session, and this is a personal perspective on returning home from a veteran who is a student here at Purdue. Also be covering carpal tunnel syndrome, especially for those in agricultural occupations. Selecting wheelchairs for agricultural use, and also an update from our USDA project leader in Washington. Final questions? Any others before we sign off? Again, just an excellent presentation. We thank you again, Dr. Reed, for taking time out of your busy schedule to be with us today and share that information. Again, follow up if you have any questions. You can send those to AgrAbility at agrability.org. I'm going to open a poll here at the end. If you have other comments, we'll just leave this open for a little while and let you go ahead and make any of the comments you would like to. Otherwise, thank you again, and we hope to have you participate again in an upcoming webinar.